The whole thing.
I'm going to get started. Good evening and thanks for joining for today's Grand Rounds. And we have something very important today. And before we go into the topic per se, let me go ahead and share the slides so that you can claim your attendance. So I'm going to go ahead. So once more, we will have our grand rounds all on the YouTube website. So even this one will be displayed up there. For the CME credit for the session, please go ahead and text 14278 to the number 888-816-4893. You have to 12 hours to do so with an active profile in the Redgo CME clouds in form of an SMS message. And for obtaining the MOC, please complete the step 1. And in addition to that, there's a brief quiz you would answer. This link will be made available in the chat box. And the room code is future26. So please stay tuned for this link to appear again in the chat box in the event you do not remember. So these 2 steps will also allow your MOC point to be credited, particularly for physicians who have an active ABIM number accredited with the Redgo CME. So with those, I'm really happy today to introduce our panelist and our guest speaker. Our guest speaker is Dr. Ambrish Pandey, and our panelists are going to be Dr. Kenneth Dalnavan and Dr. Anthony Altobelli. So with regards to Dr. Ambrish Pandey, I came to know Dr. Pandey very recently when I was in West Virginia University. We worked together on a grand challenge with the NHLBI, and as much as has been already spoken about him, he's very talented, very inquisitive, and very, very smart. So he reached out to me trying to understand how to use machine learning. Not that he did not know, he had all the skill sets, but he wanted to tap in and see what resources we had. And we had a very successful time. He not only had his team work with us, but also he was the Young Investigator Award finalist at the American Society of Echo, and this was incredible and opportunity. We also went ahead and won the NHLBI Big Data Challenge during the same time, and with a very nice publication that was in JACC Imaging. But I think it is very important for us to recognize that Dr. Ambrish Pandey, who's an assistant professor of medicine at UT Southwestern at Dallas, Texas, and also an associate program director of the cardiovascular fellowship program. He also is the director of the heart failure with preserved ejection fraction at the clinic there. His origins are from the same city where I also did my cardiology training. We did it together, not together in the sense we were from the same institute, All India Institute of Medical Sciences, in different years, obviously. I didn't know him at the time, but then he migrated here, and following his cardiology, he had his internal medicine at UT Southwestern, and also his cardiology at UT Southwestern. Before that, he had some research that he did at Brigham and Women. Following that, he's been extremely prolific in his field. So in a very short span, he has amassed an enormous volume of publication, and in fact, very rare to see early stage career person at his level having over 240 plus publication in very high impact journals, Circulation, one after the other, JACC and JACC Imaging, and so many other journals. He is not only just published, but also has been grant funded. And recently he has had an R01, which he's doing together with his mentor in UT Southwestern. And and also if you look into his list of awards, he has almost every single scholarly young investigator award, everything checked mark, best reviewer, um, everything checked mark. And what is more incredible is for me to see, and very satisfying, is to see that each time I have tried to make a phone call to him, I've heard on the background his children speaking and crying. So I understand. So with two daughters, or
Yeah, two
yeah,
daughters.
two daughters. So with a busy young family, despite that, he balances out the time and gets the work done. This just is incredible, and never ever had. It's not the question of support or grants. It's just the way you lead a life which is very fulfilling and promising. It's just he's just I would say for my other fellows that this is he soon is going to be an icon, believe it or not, in over a short period of time. As much as I know, his trajectory is very steep. And today he's going to discuss with us his thoughts about heart failure, preserved ejection fraction. And Amrish, the floor is yours, but at the same time, I wanted to let you know that the panelists are really very well talented, and Dr. Dalnawan is from the advanced heart failure practice perspective, he will bring in. And Dr. Altabali is our clinical chief of cardiology. He will provide from the community perspective of what the spectrum of issues that we are encountering. So hopefully we can have a good discussion at the end. Thank you. Amrish, the floor is yours.
Thank you so much, Dr. Sengupta, for that kind introduction and for this incredible opportunity to come and talk virtually to the program at Rutgers. Really excited to be here and to share some of our findings and thoughts on heart failure with preserved ejection fraction. The case we are trying to make today is whether it's a case of failing heart or failing body, and how does this dichotomy inform management of heart failure with preserved ejection fraction. So here are my disclosures for this talk. So the aging of the population over the last several decades has translated into relatively predictable changes in the burden of common cardiovascular conditions in the population. Shown here are the age-related prevalence of coronary artery disease on the left and heart failure on the right. Color-coded in pink and blue are men and women respectively. And as you can see, across increasing age bands, the prevalence of both coronary disease and heart failure increases dramatically. And despite the aging population, we have witnessed a remarkable change in the burden of coronary artery disease, such that over the past 40 years, we have seen up to 50% decline in coronary artery disease related mortality rates. And this reflects both the dramatic changes in the population burden of traditional cardiovascular risk factors such as smoking and hypercholesterolemia, as well as development of successful treatment of common coronary heart disease risk factors with statins and more aggressive blood pressure management. And if you contrast this dramatic decline in coronary heart disease associated mortality over the same period of time with that of heart failure, we see that we have witnessed almost no change in the incidence of heart failure and its prevalence over the past 40 years. If anything, there has been a steady increase in the overall burden of heart failure over the past many years, driven by aging population and greater survivorship in patients with coronary heart disease, valvular heart disease, all of which eventually lead to the complication of heart failure development. And a more careful consideration of the rising burden of heart failure demonstrates a more complex story. Shown here is the distribution of ejection fraction among a representative sample of patients with heart failure. And you see that it demonstrates a bimodal distribution with a large proportion of population with low ejection fraction, and then a large proportion of population with a normal ejection fraction or ejection fraction greater than 50%. And these data demonstrate that the burden of heart failure with the normal or a preserved ejection fraction is indeed very common, and more so in older population. And if you look at the lifetime risk of heart failure with preserved ejection fraction, or what we commonly refer to as HFpEF, it is pretty high. The graph here shows the lifetime risk of HFpEF at the age of 45 in men and women, and age here is the time scale on the x-axis, and cumulative incidence of HFpEF is on the y-axis. And as you can see, both men and women have a lifetime risk of HFpEF that is in excess of 10% for an index age of 45 years, highlighting the high burden of HFpEF for both men and women. And it is particularly common in older adults. Several community-based cohort studies have demonstrated that greater than 50% of all heart failure occurring in the community is HFpEF for individuals over 65 years of age. And if you further narrow down the population to looking at older women, this proportion goes up further to 80%. And these findings have been confirmed in multiple NIH-funded population studies, and these findings continue to be true as over the series of epidemiological studies that have been conducted across these cohorts. And the burden of HFpEF has been increasing over the past decade or two across most sex and race-based groups. The graph here shows the temporal trends in the hospitalization for overall heart failure, HFpEF, and heart failure with reduced ejection fraction, or HFrEF, in the ERIC surveillance cohort of over 40,000 heart failure hospitalizations between 2005 to 2014. And as you can see here, the annual rate of HFpEF incidence, which is shown by the blue line, has increased in both men and women across both races in the last decade. And the slope of this increase seems to outpace the temporal increase that is noted in heart failure with reduced ejection fraction, or HFrEF, shown by the red line in these plots. And not just the incidence is increasing, it is also worrisome that the outcomes associated with HFpEF are just as worse as they are for HFrEF, as evident by the nearly overlapping survival curves for the two heart failure subtypes shown here from a cohort of heart failure patients from the Mayo Clinic. So what about treatment? While several guideline-directed medical therapies exist for HFrEF, which have been shown to be effective in lowering mortality, improving rehospitalization rates, and improving quality of life among patients with HFrEF, our toolbox for pharmacotherapeutic management for HFpEF was largely empty till a year ago when the first drug, SGLT2 inhibitors, were shown to meaningfully improve clinical outcomes in these patients in large clinical trials. And before the SGLT2 trial, there were several other studies that were done in an effort to treat HFpEF. So far more than 8 different classes of cardioprotective therapies, actually now 9 different classes of cardioprotective therapies have been tested in HFpEF population and failed to meaningfully improve clinical outcomes, including the drugs that are shown on this slide and ARNIs or Entresto, which is a more novel renin-angiotensin pathway inhibitor. So thus, HFpEF is the single greatest unmet need in the field of cardiovascular medicine that needs our urgent attention in its management and prevention. So to understand how we can address this unmet need, let's take a step back and consider a case of HFpEF. So here we have a 65-year-old female who presents with exertional dyspnea and lower extremity edema. She's otherwise healthy other than a past history of hypertension. And on exam, her blood pressure is a little elevated. She's overweight or slightly obese and has signs of volume overload with elevated JVP and low extremity edema. Her labs are notable for mildly elevated creatinine and a BNP that seems elevated as well. And her echo demonstrates evidence of concentric LVH, left atrial enlargement, and Doppler evidence of elevated E by E prime, which usually translates to diastolic dysfunction. So the clinical diagnosis of HFpEF here is largely relied by signs and symptoms of heart failure in the setting of a normal ejection fraction. However, there is evidence of abnormal cardiac substrate, which is evident in this particular case with abnormal diastolic function, cardiac remodeling pattern, and elevated levels of natriuretic peptides suggesting increased neurohormonal stress. So this was the traditional model of HFpEF, where the central role of abnormal cardiac substrate was considered to be the key driver of HFpEF for nearly 4 decades. And this paper, which was published actually 4 decades ago by Eric Topol in a seminal study, which kind of established the initial platform for our understanding of HFpEF as a disease of diastolic dysfunction. And I think this paper in New England basically encaptured HFpEF as a disease of myocardial stiffness, which is similar to what happens in hypertrophic cardiomyopathy, except that there's no obstructive physiology, but rather stiffness associated with elevated filling pressures in the left side of the heart. And his And historically, the underlying pathophysiology of HFpEF has always been of diastolic dysfunction. And even in the past, it was termed as a diastolic heart failure. And this slide provides a simple schematic for diastolic dysfunction, demonstrating the challenges that occur during the filling of a ventricle in diastole. So shown here is a graph of relationship between LV volume on the x-axis and LV pressure on the y-axis, beginning at the start of diastole. Throughout the diastole, the ventricle fills, and in normal circumstances, the ventricle can accommodate a large increase in volume with minimal increase in pressure, as shown by the pressure volume curve in the black color. However, in the setting of diastolic dysfunction, the ventricle is stiffer, and the end diastolic pressure curve is shifted upwards and to the left, such that at the beginning of diastole, the pressure is already higher than normal, and also with increasing volume through diastole, the pressure increases much more dramatically, as shown by the red curve on this graph. And it is generally agreed that this invasive observation is the key pathogenomic feature of HFpEF and diastolic heart failure. And it is really important to understand this upward and leftward shift in the filling pressure volume relationship that has been captured as the key hemodynamic feature consistent with HFpEF. And this is also evident in non-invasive strategies for diagnosis of diastolic dysfunction using Doppler echocardiography. Shown here are the mitral inflow patterns during early diastole or the E wave, and later during atrial contraction or the A wave. In normal circumstances, the bulk of diastolic filling occurs passively during the early portion of diastole. However, in the setting of diastolic dysfunction, this process is blunted and the diastolic filling occurs more by atrial contraction during the latter part of diastole, as shown by the curve, as shown by the E by A pattern here in the bottom of the slide. The other dominant feature besides diastolic dysfunction that has been noted in HFpEF is of left ventricular hypertrophy and LV remodeling. And shown here in the schematic are the four categories of ventricles categorized according to left ventricular thickness, the relative thickness of the left ventricular walls in the vertical direction, and the increasing mass of ventricle in the horizontal direction. HFpEF is usually characterized by increase in LV mass and or increase in relative wall thickness, characterized by one of these two groups of concentric hypertrophy, concentric remodeling, and also in some cases, eccentric hypertrophy. The higher burden of concentric LVH in HFpEF is largely reflective or considered to be reflective of the dominant role that hypertension plays as it contributes to the shift in the pressure volume curve shown on the previous slide to upwards and towards the left. So if this understanding of HFpEF pathophysiology were true and common, why have the HFpEF therapies that have targeted cardioprotective mechanisms failed? And this recurring finding of lack of effectiveness of different cardioprotective therapies from the clinical literature is what makes us question the accepted cardiocentric paradigm of this disease that was propagated 40 years ago with that Eric Topol paper. Consistent with the accepted paradigm of HFpEF that implicated hypertension, left ventricular hypertrophy, and diastolic dysfunction, most agents used in trials to date before SGLT2 inhibitors were all known to have favorable effects on cardiac remodeling, diastolic function, but even then they failed to improve meaningfully the cardiovascular outcomes in these patients. And a closer look at the cardiac structure and function of patients with HFpEF who were enrolled in these clinical trials actually gives us the answer and paints a slightly different picture from what the accepted notion of HFpEF is. When you look at the data from iPreserve, CharmPreserve, and TopCat, the three large trials that tested the ARBs and mineralocorticoid receptor antagonists in HFpEF, you see that up to 1/3 of these patients had no abnormality in resting measures of diastolic function, as shown in the graph on your left. And even in the most recent Paragon trial, which tested sacubitril/valsartan, in patients with HFpEF, 32% of the patients, so 1/3 of the trial population, had no evidence of LVH, diastolic dysfunction, or elevated tricuspid regurgitation velocity, as shown in this Venn diagram from imaging secondary analysis of the Paragon trial led by Amir Shah. So thus the cardiocentric approach misses the target in a large proportion of HFpEF patients who have no worse resting cardiac structure and function abnormality than age-matched control. I would emphasize the resting aspect of this cardiac structure and function assessment because most of these studies did not look at exercise E by E prime or exercise diastolic function, and there may have been abnormalities in exercise function that could have been missed on these resting echoes. However, considering the large proportion of patients that have normal cardiac parameters, there is a need for novel approaches to understanding and targeting HFpEF pathophysiology that goes beyond just looking at cardiac structure and function. And a common theme underlying the heterogeneity in development of heart failure and HFpEF has been the role of physical inactivity and low exercise capacity, such that physical inactivity and low exercise capacity in midlife are key factors associated with development of heart failure, particularly HFpEF. These data come from a lot of the work that we did in different epidemiological cohort studies, trying to understand what drives development of HFpEF as the first step to develop effective therapies for treatment of the disease. We observed that the risk of heart failure associated with physical inactivity is largely heart failure with preserved ejection fraction, as shown in the graphs here, which show the dose-dependent association between increasing levels of physical activity on x-axis and risk of the two heart failure subtypes, HFrEF on your left and HFpEF on the right. And as you can see here, the dose-dependent inverse association between high physical activity levels and lower risk of heart failure was only observed for HFpEF, but not for HFrEF. And we observed a similar pattern of significant dose-dependent association between increasing levels of cardiorespiratory fitness, which is basically objectively assessed exercise capacity, and risk of HFpEF, but not HFrEF among patients with type 2 diabetes who were part of the Look Ahead trial and underwent objective fitness assessment by treadmill testing at baseline and had downstream follow-up to a certain heart failure events and the subtypes of heart failure. The forest plot here shows the hazard ratio 95% confidence interval for the heart failure outcome on the x-axis, and the fitness categories are shown on the y-axis. And as you can see, increasing fitness levels at baseline was associated with a graded decrease in risk of HFpEF, shown in the forest plot on your right, but such observation was not noted for HFrEF, which is shown on the graph on your left. Furthermore, when we have looked at longitudinal follow-up data, we observed a significant and meaningful decline in fitness or 4-year follow-up among the same Look Ahead participants who went on to develop HFpEF after those 4 years in a 12-year follow-up, as shown in this graph here by the orange bar. And in contrast, individuals who did not develop HFpEF for the follow-up period did not have a significant fitness decline, as shown by the blue bar here. Taken together, these observations suggest that accelerated decline in exercise capacity or physical activity levels may be an important pathway to development of HFpEF, whereby once the declining fitness level gets below the threshold for symptoms, we begin to see clinical manifestations of heart failure, which are basically exercise intolerance with routine ADLs and routine physical activity levels or less than moderate exertion levels. And this is also important because exercise intolerance is one of the key manifestations of clinical HFpEF. Among older HFpEF patients, the peak exercise capacity during upright exercise is below the VO2 level, distinguishing between high and low physical function. And as a consequence, many basic and instrumental activities of daily living require near maximal effort from patients who have HFpEF, and that's what precipitates them into going into this vicious cycle of exercise intolerance, volume overload, and presentation to the hospital. Exercise intolerance is preceded by decline in exercise capacity, as we saw in our data from the Look Ahead trial, which is measured objectively as peak exercise oxygen uptake. Now, peak exercise oxygen uptake is a cross product of peak exercise cardiac output and peripheral oxygen extraction, and therefore reduced peak VO2 can occur from abnormality in exercise hemodynamic reserve for cardiac output, as well as exercise hemodynamic reserve for peripheral oxygen extraction. We have demonstrated that healthy aging, which happens without development of HFpEF or any other major cardiovascular abnormalities, is also associated with decline in exercise capacity or peak VO2, but that is largely driven by decline in exercise cardiac reserve, as shown on the right, with no significant change in peripheral oxygen extraction. So healthy aging is basically decline in cardiac exercise reserve and not decline in the ability to extract oxygen at peak exercise in the skeletal muscles. In contrast, in patients with HFpEF, our group has demonstrated that exercise intolerance is manifested by not only declining peak exercise cardiac reserve, but also by decreased peripheral oxygen extraction reserve. And the graph on your right shows the relative contribution of impairment in different components of Fick equation to the low exercise capacity in HFpEF versus matched controls. As you can see, besides impairment in different cardiovascular exercise reserves, decreased peripheral oxygen extraction reserve is one of the strongest driver of low peak VO2 in HFpEF versus control. On this graph, on x-axis, basically we are showing the different parameters from the Fick equation, and the y-axis we have the standardized mean difference in these parameters at peak exercise among HFpEF versus control group. So the negative value represents more impairment in those parameters, where the positive value indicates higher levels. So a peak AVO2 difference is one of the top 3 parameters that is impaired in patients with HFpEF that drives their reduced exercise capacity, which is different from what we see with healthy aging. And thus, the key contributors to exercise intolerance in HFpEF are not only impairments in cardiovascular exercise reserve, but also impairment in peripheral vascular function and impairment in skeletal muscle and microvascular architecture, such that there is reduced vasodilatory reserve in the extremities, reduced capillarity, sarcopenia, muscle fat infiltration, and reduced mitochondrial function, each of which drive the reduction in the peak exercise peripheral oxygen extraction and exercise intolerance in these patients with HFpEF. And besides exercise intolerance, patients with HFpEF also have high burden of non-cardiac comorbidities, as shown in this graph here, which demonstrates a much higher proportion of HFpEF patients, shown by the black bar segment, versus HFrEF patients, shown by the orange bar segment, across the spectrum of increasing burden of comorbidities among patients with ambulatory heart failure. Similarly, in a recent study from Eric's surveillance cohort, we also observed that the burden of non-cardiac comorbidities in patients hospitalized with HFpEF and HFrEF has increased over time, with a higher burden of these comorbidities in HFpEF patients than HFrEF patients at any time point, as shown in these trend plots on your right. The blue line represents HFpEF cohort and the red line represents HFrEF cohort in these graphs. Furthermore, higher burden of comorbidities is also associated with high risk of 1-year mortality in both HFpEF and HFrEF, with a significant interaction by heart failure subtype, such that the higher burden of comorbidity was associated with greater risk of mortality in HFpEF than it was in HFrEF. And the higher risk of mortality associated with greater comorbidity burden has also increased over time, highlighting the increasing medical complexity of patients with HFpEF over time, which has been another challenge in how we approach management of this disease. So besides exercise intolerance, multimorbidity burden, another important geriatric factor that is contributing to HFpEF is frailty. Frailty is a biological syndrome that reflects a decreased state of physiologic reserve that increases the vulnerability to stresses. And there are 2 distinct pathways that have been proposed for development of frailty. One pathway is shown on the left side of this flowchart that involves upregulation of inflammatory mechanisms, androgen deficiency, increased insulin resistance, and sarcopenia, which manifests into the frailty phenotype with more physical function impairment, slowness, weakness, decreased muscle mass, inactivity, and exhaustion. The other pathway is related to aging-related wear and tear that is worsened by prevalent diseases and leads to subclinical multi-system dysfunction and manifests as the frailty phenotype that is shown on the pathway on your right. And pathogenesis of HFpEF shares a lot of common features with frailty pathways described here. And even early stages of frailty, described as pre-frailty, are associated with increased risk of HFpEF, as shown in these data, which come from the ERIC surveillance cohort study, where individuals underwent frailty assessment at baseline and had heart failure outcomes assessed on follow-up. And as you can see by the cumulative incidence curve for pre-fail patients, shown with the red line, there is a much higher cumulative incidence of HFpEF among those patients as compared to the matched control group patients shown by the blue line. And the burden of frailty is high, particularly in patients with HFpEF, as has been demonstrated in some recent studies, one of which is shown here from the rehab HF trial cohort, where up to 60% of patients with HFpEF had frailty burden, shown in the graph on your left, and the burden of frailty in the HFpEF patients was much higher than that noted in the HFrEF group, as seen in this study. And in the TOPCAT trial, which included chronic stable patients with HFpEF, the burden of frailty was even higher, up to 70%. And this higher burden of frailty in HFpEF has been associated with increased risk of adverse outcomes of heart failure hospitalization and mortality, as shown in these forest plots from the TOPCAT trial cohort. And as we see here, as the frailty burden increases, reflected by increasing class of frailty index, there is a graded increase in the risk of heart failure hospitalization, shown with the forest plots on your left, and all-cause mortality, shown in the forest plots on your right, in this patient population of chronic stable HFpEF. So putting this all together, HFpEF has all the features of and is now accepted as a true geriatric syndrome with important contributions of key geriatric factors like sarcopenia, high comorbidity burden, frailty, and functional impairment to development, manifestation, and progression of HFpEF. The flowchart puts this all together in a really nice way and captures the current understanding of HFpEF pathogenesis as a true geriatric syndrome, highlighting the contribution of different key geriatric factors in the process. Accumulated exposure to risk factors such as aging, comorbidities, inflammation, and inactivity leads to sarcopenia, mitochondrial dysfunction, capillary loss, endothelial dysfunction, and this manifests in the reduced physiologic reserve or frailty and downstream manifestation of cardiac dysfunction, skeletal myopathy, multi-organ dysfunction, which culminates into this clinical manifestation of HFpEF, which involves greater functional impairment, impaired quality of life, increased risk of hospitalization and death, and higher cost burden on the health system. So the gerocentric approach to management of HFpEF aims to use these principles of geriatric medicine to target the high frailty burden, the exercise intolerance, and the comorbidity burden to improve functional outcomes. And this is particularly relevant and timely considering the shifting focus from hard clinical endpoints to functional outcomes for evaluating effectiveness of treatment strategies in heart failure as mandated by FDA. And consistent with the gerocentric focus, Gordesky and colleagues have proposed a domain-based approach to management of HFpEF, whereby specific deficits in medical, physical function, cognitive, and social environmental domains need to be addressed for overall improvement in patient functional status, clinical outcomes, and quality of life. So for the purpose of this talk, we are going to focus on the medications as there have been recent advances in HFpEF-specific therapies that have shown to improve outcomes, and also on optimization of management of comorbidities that are commonly present in patients with HFpEF. And the second aspect that we are going to focus on in terms of management is exercise, where we have a lot of emerging evidence on how exercise can actually target these impairments in different physical function domains and improve outcomes in patients with HFpEF. So coming to the exercise management part first, exercise training is one of the interventions that in the physical function domain that has been shown to improve exercise capacity in patients with HFpEF. The first plot here comes from one of the meta-analyses done by our group, where we observed a significant 15 to 20% improvement in exercise capacity of patients who were randomized to supervised exercise training in these exercise training trials compared to usual care. And this improvement in exercise capacity was also associated with significant improvement in quality of life among patients who underwent supervised exercise training, as shown in the forest plot on your right. Furthermore, the fitness improvement in response to exercise is much more robust in patients with HFpEF versus HFrEF, as shown in this study by our group, where we had 24 patients with HFpEF and 24 with HFrEF undergo identical supervised exercise training regimens for over 16 weeks, and patients with HFpEF had an average 20% improvement in exercise capacity as compared to less than 1% improvement in those who had HFrEF. And some important data on exercise related improvement in outcomes has emerged from the HF-Action trial cohort, where our group has shown that frailty status, which is very common in patients with heart failure, actually modifies the benefits achieved by exercise training in patients with chronic heart failure with reduced ejection fraction. In these data from the HF-Action trial, which is one of the seminal exercise training studies in heart failure, there's a 17% reduction in adverse clinical outcomes in frail patients with no benefit in non-frail patients, which was largely driven by difference in heart failure hospitalizations. So the graph here shows the increasing frailty burden on the x-axis and the treatment effect on the y-axis for the exercise training, with a less than one treatment effect showing less likelihood of having adverse outcomes. And as the frailty burden increases, the treatment benefit from exercise training increases, suggesting that exercise actually targets the key impairments that puts these frail patients at the highest risk of having this disease, but that is also modifiable with exercise training interventions. While the data for exercise training is really positive or encouraging for HFpEF, sadly, exercise training in form of cardiac rehab is not currently approved for coverage in patients with HFpEF. And this poses a major challenge to use of exercise training as a treatment strategy in patients with HFpEF right now. And all it is approved for currently is chronic stable HFrEF, where the benefit is much lower, but particularly in all comers with HFpEF as compared to patients with HFrEF. And even among patients with heart failure where the CMS has approved cardiac rehab, the participation in supervised exercise training is very low for heart failure. These data come from Medicare administrative databases, where we have looked at proportional participation in cardiac rehab since its approval for CMS coverage in 2014 among Medicare beneficiaries with diagnosis of HFrEF, and only 5% of patients who qualify for cardiac rehab actually participated in cardiac rehab sessions in the 2 years after approval of cardiac rehab coverage for heart failure, highlighting a big implementation gap that exists for utilization of cardiac rehab for management of patients with heart failure. And this highlights the need for more innovative models of exercise training intervention in patients with heart failure at large, but particularly among patients with HFpEF, where these therapies are still not approved by insurance coverage. And to this end, there's been a recent study, the REHAB-HF trial, that has provided us with a lot of hope in the multi-domain physical function intervention for management of older, frail patients with heart failure, particularly HFpEF. In this trial, around 400 patients underwent 3 months of early transitional, tailored progressive multi-domain rehabilitation that began during the hospitalization and continued for 3 months post-discharge, with the intervention aiming not just at cardiac rehab or exercise capacity, but also on other domains of physical function, such as improving balance, strength, mobility, and then targeting endurance. So really a gerocentric focus intervention that was studied in patients with heart failure. And this trial demonstrated significant improvement in SPPB, quality of life, and 6-minute walk distance. SPPB is a measure of physical function in these patients. And the key finding that was most interesting for me was that the benefits of this multi-domain physical function intervention varied by heart failure subtype, with a much greater improvement in these parameters in patients with HFpEF, as shown in these graph here, as compared to those with HFrEF, which are shown by the red bar. So as you can see, the effect size for each of the outcome was much higher for HFpEF patients, who are shown by the blue bar, compared to the HFrEF patients. And consistent with the domains that we talked about earlier, now let's transition to the medications that have been shown to have effectiveness in treating patients with HFpEF. So most of you are probably familiar with one of the most important trials to come out in the last 24 months or so, which was the EMPEROR trial, EMPEROR Preserve trial specifically, that showed for the first time that a pharmacotherapy could improve clinical outcomes in patients with HFpEF. So this trial tested empagliflozin in heart failure with preserved or mildly reduced ejection fraction and demonstrated a 21% reduction in the primary outcome of worsening heart failure or CV death. And more importantly, this improvement in outcome was consistent across the EF spectrum, as shown in the graph on your right, where there's no significant effect modification across EF distribution, suggesting that this therapy actually provided improvement irrespective of whether they had mildly reduced ejection fraction, low normal ejection fraction, or supernormal ejection fraction, and was a major advancement in how we can treat and manage HFpEF. And these findings were further replicated by the second trial of this class of drugs, dapagliflozin, in the recent study, the DELIVER trial that was published in New England and presented at ESC a month ago, where dapagliflozin was associated with a 18% reduction in the risk of worsening heart failure or CV death compared to the placebo, with the same consistent benefit across the EF distribution, again highlighting the robustness in its treatment benefit, irrespective of where the patient lies on the EF spectrum. Also, more importantly, a secondary analysis from this DELIVER trial was published simultaneously, where it showed greater benefit in frail patients with the use of SGLT2 inhibitor, and that is shown in these interaction curves, where you have frailty index on the x-axis and hazard ratio that demonstrates treatment benefit on the y-axis. Again, a hazard ratio less than 1 shows more benefit. So as you can see, for the worsening heart failure cardiovascular death, there is a trend towards increasing benefit among patients who are more frail, and that is further exaggerated for worsening heart failure hospitalization. So more frail patients who are on SGLT2 inhibitor had more benefit in reducing heart failure hospitalization with these drugs. This is similar to what we saw with exercise training in HF Action, where more frail patients benefited from exercise, again highlighting that these therapies that target multi-domain cardiometabolic and peripheral targets have a pretty robust improvement in outcomes in patients who have more deficits in these domains. In contrast, another drug that has been of interest for treatment of HFpEF has been angiotensin neprilysin inhibitor, or sacubitril/valsartan, which was tested in a phase 3 trial called Paragon, where it actually failed to meet its primary endpoint with a non-significant 13% reduction in the primary composite endpoint, and also lack of treatment benefit in the patients who had higher or normal EF, which is what you see with HFpEF patients, as shown in this graph on your right, where you see a robust benefit in low or mildly reduced EF, but not really any benefit in the EF spectrum above 55 to 60%. And then one last drug that is, I think, really important and kind of undersold in when it comes to management of HFpEF is spironolactone, which was tested in the TopCat trial. And while the primary trial outcome was null with a non-significant 11% reduction in the primary endpoint, there was significant regional variability, and due to challenges with recruitment of the right patient population in 2 of the major recruiting centers in Russia and Georgia, the overall trial outcome was null. But among the patients from the Americas centers, there was a significant improvement in outcomes among patients who received aldosterone antagonists or spironolactone than patients who were on placebo, suggesting that there is some value in this therapy among patients who have been correctly diagnosed with heart failure and have received the drug. So coming to how we focus on management of HFpEF based on all the evidence that I presented. So informed by all this knowledge from our group's work and from other groups' work and the recent trials, we have developed a gerocentric focused HFpEF clinical program at UT Southwestern. This program focuses on first adequate phenotyping, so detailed functional assessment, exercise capacity assessment, geriatric focused phenotyping with frailty assessment, quality of life, cognitive function. And then we focused on initiation on evidence-based therapies that have substantial benefit in patients with HFpEF. And the 2 classes that we go with are SGLT2 inhibitors and mineralocorticoid receptor antagonists based on the evidence that we just presented. And then we use the other pharmacotherapeutic approaches to manage their comorbidities, to optimize blood pressure control, optimize diabetes management, and use diuretics as needed to optimize congestion management. We also focus on home-based exercise intervention that is provided to patients in our clinic using an mHealth-based platform as a strategy to improve their physical activity and physical function. We also provide dietary and nutrition counseling. We provide weight loss strategies with the emerging GLP-1 agonist therapies now, because a lot of these patients are overweight and qualify based either on diabetes or cardiovascular risk. And then among patients who are not improving in their symptom burden, we explore additional etiologies that may underlie their exercise intolerance. So in conclusion, HFpEF is a systemic disorder with multi-organ involvement, and moving away from a cardiocentric focus to a gerocentric focus may help us better address the deficits that drive a lot of the symptom burden in these patients. Accelerated age-related fitness decline, accumulation of comorbidities, skeletal muscle dysfunction, and frailty are some of those key gerocentric factors that contribute to exercise intolerance in HFpEF. Management of HFpEF should target pharmacotherapies like SGLT2 inhibitors, MRA, and diuretics, and should be supplemented with exercise and physical function interventions that can actually improve these deficits and improve their functional status. With this, I would like to end by thanking my mentors and collaborators and funding sources that have made a lot of the work that we've done possible, and would love to take questions and any comments on this. Thank you.
Great. Thank you very much, Ambrish. If we will want to bring back our panel, so if you want to unshare your screen, then I think we'll bring back Dr. Altobelli and Dr. Kenneth Dolnawan. And please feel free to put your questions in the chat. So
how to unshare my screen? Okay, here.
Perfect.
All right.
Yes, there you go. So great. So my first question would start with Ambrish. So it seems like heart failure preserved ejection fraction seems to be a very problematic and with typically not really great responses seen in the past, but now we have something on the horizon. How would you organize a heart failure preserved ejection fraction clinic? And is it a multidisciplinary clinic? How do you do it, and how you're doing it in your health system?
That's a great question. This was one of the key questions that we had to answer before we started our HFpEF program 2 years ago. The most important thing is identifying patients who need to be seen in the clinic. And I think the way we developed it is by reaching out to the hospitalists, to the general internal medicine providers, the geriatric clinic providers, and developing an EMR-based approach where all of us use the same EMR, all of us are seeing the same encounters. And we developed an algorithm using EMR-based diagnosis codes, lowing codes, use of medications, and existing risk models like the H2PEF score that Mayo Clinic has developed to do the first pass enrichment of patients who most likely have HFpEF in both outpatient setting and inpatient setting. Once we did that, we developed a funnel system where all those referrals came to our program. And then based on the clinical chart review, we were able to identify who would benefit from further phenotyping or who has advanced lung disease or end-stage cancer, where the return on investment because of competing risk is not going to be as high. And then we narrowed down our list to most likely HFpEF with no other obvious etiology of exercise intolerance by excluding patients with advanced kidney disease, advanced liver disease, and valve disease and things like that. And then we end up with a cohort of patients in whom we do the invasive hemodynamic phenotyping, we do exercise capacity assessment, functional status assessment. And in our clinic, 80% of the patients who pass through this filtering system in EMR, that is all EMR based, end up with invasive hemodynamic assessment-based confirmation of HFpEF diagnosis. 20% patients end up not getting it, and then they are sent back to the provider. So it's like an approach that is definitely multidisciplinary, but that doesn't require providers to be in the same clinic, but more like providers to collaborate on a cloud-based system or a EMR-based system to make sure that any patient that has exercise intolerance, they think of HFpEF, they get the biomarker testing, they get the exercise testing and echo, and that can feed into our EMR algorithm to identify the HFpEF patients.
So let me ask you, and I know that our panelists will also like to chime. So let me ask you a very pointed question. Is there any data that organizing a heart failure preserved ejection fraction clinic separately from what a general cardiologist can take care of this patient makes a difference in how you approach these people in terms of outcomes? Why would not anybody just be able to treat? I'm just saying, why should we refer to a specialized clinic? I'm purposefully.
That's a great question. That's a very
raising
practical
this question. Yes.
Right, that's a very practical question. My answer would be the organized effort that is needed across multiple domains to phenotype and to manage these patients requires a specialized focus. If you look at a general cardiology clinic, we have 25 patients in a day and on a light day, and the ability to focus on the multi-domain nature of the symptom burden, the multi-domain nature of the required treatments is not there. And on my HFpEF, before I started the HFpEF program, I was actually in the general cardiology clinic, and I would see these patients, and 20 minutes to work up a patient on a follow-up day is just not enough. And there was no organized effort to assess 6-minute walk distance or to do peak VO2 assessment. And so I think because of the comprehensive nature of the deficits that patients with HFpEF have, I think we need a dedicated effort to organize and focus on their workup and their management. So there's no data yet because we haven't published any data yet from our program, but I bet if we look at all these specialized HFpEF centers like what Sanjeev Shah is running, Barry Borlaug is running, Greg Lewis is running, Glenn Kisman is running, and that's part of the HeartShare that has now become an NHLBI funded program. I think the phenotyping and the management has to be better because we are identifying more cases and we are able to target them with now effective therapies.
Okay, I'm going to open it up for Dr. Altabali and Dr. Delnova. Anthony, do you want to start with any questions or comments you will have?
Yeah, Ambrish, thank you. Really an all-encompassing discussion of a very important topic. I want you just to get some, I have two things. One, I just want you to provide some comments on the obesity paradox in heart failure. And I think to a certain extent, you address this with frailty and fitness. We know that despite increase in type 2 diabetes and cardiovascular disease in the obese patients, we know that an increased BMI actually affords a survival benefit. And it's seen in HFrEF, but not in HFpEF. And I think when they did a retrospective analysis at TopCat, they saw that. Do you think that that's a function of fitness versus weight or body mass index? And how does that play a role in when you're evaluating your patients, particularly those who are in the mid-range ejection fraction? Because we know we use the EF of 50 as our arbiter for reduced or preserved, but we also know that people move, their ejection fractions move as their hemodynamic status move, and sometimes they're not static in terms of their EF.
No, that's a great question. I think that the question of obesity paradox is really important for not just heart failure, for any, if you look at cardiovascular disease mortality signal, there is an obesity paradox that has been documented for most cardiovascular diagnosis outside of, I think, even for HFpEF, there is an increased risk of heart failure hospitalization, but I think lower risk of mortality. We did a second analysis in TopCat where we had seen that. And I think the obesity paradox is more of an epiphenomenon. If you look at any obesity paradox paper and compare the age of the severely obese or class 3, class 4 obese and the normal weight, there is a difference of 15 to 20 years, 15 to 20 years in the age of severely obese who are younger by 15 to 20 years compared to the normal age. So I think a lot of what you see in obesity paradox is basically earlier stage disease that has been diagnosed early or less severe patients. And you can try to adjust it off with the adjustments, but I think it never completely attenuates the marked difference in age. That is one of the strongest predictors of mortality. And the reason I believe it's not a true biological phenomenon that is specific to heart failure, because it is seen consistently across every cardiovascular disease obesity paradox literature that you look at. And in heart failure, Chip Levy's group has actually looked at this, where obesity paradox was all mediated by fitness differences. So those obese younger patients who had lower mortality risk had higher fitness level. And when you look at HFpEF, the age range in HFpEF is narrowed because HFpEF is mostly a disease of older patients. So your obesity paradox becomes more blunted because now you have a narrow range to look at differences and reverse confounding by age. And the fitness is much lower across the board. So your fitness differences are also blunted. So you tend to lose the obesity paradox effect in HFpEF patients, particularly when you look at true HFpEF patients who have a hemodynamic based diagnosis. And one last point I would like to make is that Barry Borlaug's group had actually done a hemodynamic based assessment of obese and non-obese heart failure patients and compared it to healthy controls. And he has demonstrated that obese patients actually have worse hemodynamics that drives worse outcomes when it comes to quality of life, hospitalization burden. And so he calls it the obese HFpEF phenotype, which is actually worse than non-obese HFpEF phenotype.
And I just want to jump in for one more question, and this is almost a policy question, and I think it's important for the participants on today's program. I have my patient, they're on an SGLT2 inhibitor, they're on an MRA, I have them in a rehab program, I'm keeping them optivolemic, they've seen a dietitian, but yet the Affordable Care Act and the Medicare hospital readmission reduction program basically grades me on rehospitalization and heart failure. Should there be a higher focus on quality of life rather than mortality and heart failure hospitalizations? I can only do so much, and I've done it all in this patient.
You're absolutely right. And this is another focus of my research interest is what is a good metric for hospital performance for heart failure. And we all have seen the downsides of focusing too much on readmission burden, where people start to game the readmissions as off stays or not admitting patients who need it. And then there's a negative association between readmission and mortality. If you die, you never get readmitted. So the best thing that a hospital can do is hope that the patient doesn't come back because they're dead. So I think that those flaws have been well demonstrated by our work and other groups' work. I think you're absolutely right that the focus has to be on patient-centered outcomes for hospital performance. And to this end, actually, we have published in Circ and JAMA Cardiology a metric called home time, where instead of looking at readmission or mortality, we calculate the number of days a patient stays at home after discharge. Every patient would love to be at home as long as they can. So it's definitely patient-centered, and it captures both mortality, readmission, but also the stay at a rehab center, not a rehab, but at a SNF or a LTAC, which also contributes to days lost from home time. So we have actually advocated in a lot of publications from our group that we should focus on a patient-centered metric like home time when it comes to assessing hospital performance, be it for heart failure, MI, TAVR, MitraClip, because that is more meaningful for patients. That is less gameable, because if you game it in one direction, it goes off in the other direction. And I think that is more comprehensive. So a lot more work is being done in this space, but I absolutely agree with you that it's not the readmission that matters the most to the patient. I think it's their quality of life. It's whether they get to go home and stay at home or not.
So, and may I invite just Dr. Dilnavan to also join in. So Dilnavan, so again, one thing that often is EF like a great number. Sometimes you see people jumping from HFrEF and then they can cross over to mid-range and then can cross over to the other side. What's been your experience managing your advanced heart failure group?
Yeah, exactly. Actually, that's one of my questions for Dr. Pandey too. Is it about time that we get rid of this distinction about HFpEF and HFrEF, especially now knowing that HFpEF is actually a huge basket of different phenotypes? I mean, is it about time that we start having different groups, just like how we do it in pulmonary hypertension? Because one of the dangers of lumping them together, you have these studies like TopCat, where you would have an overall negative study. But going back to your question, Dr. Sengupta, yeah, so the good thing at this point is that with HFrEF, we have a lot of tools that we can use at our disposal. Case in point, we have heart transplant. Despite being the equivalent mortality between HFpEF and HFrEF, we know that the HFpEF patient actually does not benefit from a heart transplant, which supports the gerocentric thinking about this HFpEF. But that being said, I think and Dr. Pandey, please weigh in, it's about time that we have to have like different distinctions between the different phenotypes of HFpEF so we can start targeting those different phenotypes with different therapies. Case in point, which one would benefit from sildenafil, which one would benefit from riociguat, and those other therapies in the future.
That's absolutely right. And I think phenomapping in HFpEF has been a big concept that I think Dr. Sengupta's group, Sanjeev Shah's group, some of our work in this space has also focused on, that HFpEF is a heterogeneous group. By default, it was made for patients who had heart failure, but didn't fit the HFrEF paradigm with EF. But I think it's not one size fit all by any means. SGLT2 inhibitors work in HFpEF because I think they target pleiotropic pathophysiological process and just don't target one particular aspect. We don't even know what they target, honestly, but we know that they target multiple things. And I think that's why the things that work in HFpEF are things that have very pleiotropic in their effect, like exercise, weight loss, SGLT2 inhibitors, more cardiometabolic focused therapies, which are multi-domain in their effects and have favorable effects on pulmonary function, have favorable effects on pulmonary blood pressure, pulmonary hypertension status, and kidney function, which is such a crucial component, and plasma volume and hematocrit, and all these aspects. So I don't think we can throw away EF, because I don't know of any other variable than EF that has a treatment interaction as strong as what we see with EF. If you treat heart failure patients with ACE inhibitor, MRA, to large extent beta blocker, EF modifies the benefit such that the benefit is only seen in low EF, but not in high EF. EF is by far an imperfect measure, but I think it's an easy measure that is available in almost every cardiology clinic or general medicine clinic now, and can give you the initial evaluation. But I think we should not stop at EF, especially in people who have normal EF. We should do more further phenotyping. An important concept is exercise testing with diastolic stress, strain assessment, because strain assessment can give you a lot more information about myocardial contractility, and also developing a multi-faceted echocardiographic I think evaluation, much like what Dr. Sengupta's group has been pushing for and doing, where you don't look at just one variable, you look at how they cluster, look at a continuous level, how different parameters will cluster, and then identify the high risk abnormal phenotype. This was the focus of our work that we did together in the NHLBI challenge, and we were able to actually develop a more sensitive measure of cardiac performance that was able to distinguish between high risk and low risk HFpEF patients and identify treatment benefits, or those who will benefit from the treatment better.
So Amrish, one point I wanted to just make, because you spoke about the strain and there was a comment in the strain in the chat box. So our work, it's been tough to enroll these patients. So when we do this multi-center studies, EF is so easy, and clinical heart failure and EF normal, you're able to enroll them. But if you look into the pathophysiological studies, we have seen that if you look into the strain from the myocardium, particularly if you look at the strain from the atrium, the atrial strain seems to be fairly, let's make a very firm statement that the central LA pressure needs to be high to be able to diagnose heart failure.
Right.
By far and large, you will see a strain abnormality either in the ventricle or in the atrium. I mean, that happens. If it is not abnormal at rest, then if we do a supine bike exercise and look at the strain, and just like Barry Borlaug has done, and there in the cath lab, you can do this kind of measures and actually diagnose, uncover the presence of HFpEF, which by the way, I think this is a very important message. So if someone you think you're suspecting heart failure, don't stop at a resting study. I mean, exercise or even put in a pulmonary capillary wedge pressure or some form of challenge and we are going to get a supine bike in the exercise lab to be able to diagnose these patients. Please continue to do that, because I think we will do a lot of injustice. And then as I also find one thing, people are very shy on using spironolactone. Yeah. And they don't use as much spironolactone. There's a lot of Lasix and other types of diuretics, but spironolactone is underutilized. I feel like they just like not even there, or 12.5 and just one tablet. No, 25, increase it up if possible, manage the potassium. And the problem is always this renal failure. But now with SGLT2 and all other therapies available, I think you may have an opportunity to use a combination. And I think some of these paradigms are going to be coming in. So a very, like you say, phenotyped, diagnosing using exercise regimen, diagnosing and understanding this phenotype is very important. And then putting them on the right medication, which includes a combination of spironolactone, SGLT2, and other things. It's very important to take care of them. And that's why you need specialized care of people. And one more last thing before, I know that there is a question about venous tone and venous capacitance. In fact, I would ask whether this is I think there's a concept of endothelial dysfunction, and maybe you can respond to that, Ambrish, in chat. But one question that I would like to ask is, how common is concomitant coronary artery disease and in HFpEF, and how often we do coronary angiograms? And if we do a coronary revascularization, does it really alter the outcomes? I'm not sure if there's any been systemic studies in these people, but given coronary artery disease is concomitantly present often, I see a lot of coronary revascularization.
Yeah, there's like
done,
the
but does it make a
coronary
difference?
CAD prevalence is like 40, 50, 60%. I think 40 to 60% in ERIC data that we have looked at, and it's high. And CAD, if you look at epidemiological data, CAD is associated with increased risk of HFpEF. Ischemia drives diastolic dysfunction. I think the first abnormality that you get with acute, acute LAD, occlusion is diastolic dysfunction before you have anything else. So I think CAD does drive diastolic dysfunction. CAD is an important risk factor for HFpEF. We have seen this in lifetime risk studies and epidemiological cohort studies. And in our setting, if the patient, a lot of patients that we see have already had CAD management with PCIs in the past, we always assess for CAD burden, because that is one thing that can also drive shortness of breath, exercise intolerance. And it's something that we do a routine right and left heart cath, and when we do HFpEF patient workup that has not had one before. So we do a left heart cath, and then we do an exercise right heart cath if we don't find a obstructive CAD. If we find obstructive CAD, we fix it, and then we bring them back. And then if the symptom is gone, then we know that they are benefiting from whatever we did. And I think, so in my mind, and I think I've talked to Sanjeev and Barry about this before as well, that CAD is an important driver of exercise intolerance and symptoms of shortness of breath with exertion. So I think that should be taken off the table in these patients, the right substrate for having a high burden of CAD. So I think that's an important consideration. And I think we can go into the arguments of ischemia trial and whether or not you should fix it, and whether or not, but if you have someone has active anginal equivalent symptoms with a high burden of poor quality of life, I think most evidence do suggest that revascularization does improve quality of life. If it doesn't make you live longer, it definitely helps you live better. So I think we go with our focus on quality of life and improving it without adding too much to the pharmacy, like the polypharmacy burden. So we do revascularize patients with HFpEF that have evidence of coronary artery disease and symptoms of exercise intolerance.
So Ken, any closing comments?
Yeah, actually one quick question. CardioMEMS, how does that play into your clinical practice?
Have been using it now. We have, I think, put in like 10 or 15 in our clinic. What I do is, and this is not driven by any like guideline recommendation, is if a patient has had a 30-day, twice they have had like 30-day readmission after discharge, then we want to closely monitor their hemodynamics and closely monitor their diuretics, because these patients are very sensitive to diuretics. So a little bit extra puts them in pulmonary edema, a little bit less puts them in renal dysfunction. Yeah. And it becomes really challenging to do a phone tag and trying to adjust their diuretics and recheck their potassium. So, and in some patients, I think where there's a very fine line or fine margins on hemodynamic optimization, we use CardioMEMS, and we have actually had a really good experience with it, where it becomes kind of an autopilot, because we give the protocol for if the filling pressure is more than 20, do this, and then they're able to do it. Obviously, we only select for patients who are going to measure their pressures at home routinely, and we can have a follow-up. If you put it in someone who's never going to follow up or measure it, then it's of no use. But if in a right patient population that has been carefully selected, I think there is value based on the evidence that exists and based on our experience with it.
And you know, I think I just want to end this with an analogy, so you can just see how all of our attendees have been really engaged and been present till the last when we have exceeded 10 minutes. So it got very exciting in the last 15 minutes, and we really covered a lot of topic. But the most important, just as soon as the excitement grew up in the last, is like the pre-systolic accentuation. Always remember that maintain a sinus rhythm, try to maintain a sinus rhythm, because AFib can really make a havoc in heart failure with preserved ejection fraction. So also there's a lot of interaction of AFib and heart failure preserved ejection fraction. So you can see it's really a challenging condition. It requires an individualized approach, as Dr. Dalnavan was mentioning. So, and having a very nuanced approach to phenotyping these patients is important. So maybe in the future, Ambrish, you'll be showing us some data that when patients go through advanced heart failure center that can phenotype and take care of them, there are differences in outcome. And sometimes that cannot be appreciated in a general cardiology clinic. So with that note, I would like to thank all the panelists and Ambrish for joining us, and I look forward to next talk next week. And I'm going to continue the phase B of heart failure preserved ejection fraction I'm going to give the talk myself, and it's going to be a suspense, and it's not going to be the same thing that Ambrish has commented. So stay aware of our next continuing theme of HFpEF. The enigma continues. So I'm going to keep that as a title. I made the title just now because I got very much stimulated by Ambrish's presentation. So let's come back next week and discuss another important concept of HFpEF. The enigma continues. Thank you.
Thank
Thank
you.
you.
Thank you.